Thank you all for coming out today. I love that everybody's coming out on a Saturday for this conference. Um, I'm finding this a very special experience, and I really want to thank all of the organizers of it because what's really special here is that this is a conference with both patients and healthcare providers. And for me, it's a special experience because I have been on both sides and am on both sides. So I feel like I'm at a conference where I can identify with everybody. So the title of the lecture was, Is it mental illness or is it Lyme? And I think you all know by now that it's both. And it's clearly both. So I'm going to talk about the psychiatry of Lyme disease. And I'm going to talk about it from two different perspectives. One of them is the neuropsychiatric. And that's what's going on a cellular level, and where can we intervene on a cellular level that's specific to this being Lyme disease. And the other is the emotional level, and that our patients all have symptoms that have to do with what it is like to have this illness, an illness that has been denied across the country by professionals, by government, by everybody, and by families, and what it's like to live with it and deal with it. It's a very special illness in that way. This lecture was basically approved by the CDC in 2006, notwithstanding anything that came after. And in 2006, the CDC declared that chronic infections by stealth organisms that are undetectable cause chronic illness and neurodevelopmental neuropsychiatric illness. So they may have changed their view since then, but at that point they were speaking truth. So can microbes cause psychiatric illness? Yes, and we've known that for a really long time. It's not anything new because we've known about syphilis for ages. And when we thought about syphilis on a regular basis, we thought all psychoses were syphilis, and we called it dementia praecox, and now we call it schizophrenia. We thought that all dementia was syphilitic dementia, and now we have Alzheimer's. We didn't have Alzheimer's 70 years ago. So we have always known that microbes can cause mental illness. A study recently that I thought was really interesting was on hospitalized patients, and it studied what happens when they leave the hospital. And patients who were hospitalized with infections had a higher rate of suicide than any other patients. And that was notwithstanding what infection they had. So what I'm talking about today in psychiatric Lyme is late Lyme. We've been calling it chronic Lyme, but I think thinking about it as late Lyme is kind of more helpful because we used to talk about late syphilis. We called it tertiary syphilis. So very early on, while Lyme disease is very active and can invade the nervous system very quickly, most of what I'm talking about are symptoms that occur over time. They occur consistently in patients who are untreated, and they occur in patients who were well treated or well treated by most standards available. Encephalopathy is widespread. Most of our patients have encephalopathy when they have late Lyme. So, there's a question of okay, it could be infectious, but is it also inflammatory, and what does that mean? Well, we do know that psychiatric disorders are inflammatory disorders. We don't know a whole lot about it yet. We're still learning. But most psychiatric disorders have been associated with cytokines, which are signaling molecules that tell the body to be inflamed. And a lot of them signal early inflammation. We have studies that are kind of like, which came first, the chicken or the egg? Did people develop inflammation because they were depressed? And so we know that children who were studied at age 8 and had all kinds of things measured and were studied over the course of time, that if their IL-6, an inflammatory marker, was elevated at age 8, they had an 80% increased risk of developing depression later in life and a twofold risk of psychotic disorders, and this is actually by the time they were 18. We also know that about a third of patients who are resistant to antidepressants show evidence of inflammation. So most psychiatric disorders are associated with some kind of marker. In the general psychiatric population, Lyme is really overrepresented. So there was a study of 900 patients who were admitted to a psychiatric hospital, and they were given Western blot testing and ELISA testing, and 33% met surveillance criteria by the CDC. And as you all know, it's hard to meet those criteria. Many people never meet them. So that was 1/3 of hospitalized patients. And then they looked to see, well, what diagnoses did they have, and how do they differ from patients who don't have positive markers for Lyme? And they didn't differ. They had the same amount of bipolar disorder, schizophrenia, and depression. So all psychiatric disorders were represented. There was a study done this year in Poland of 121 patients who had neuro-Lyme. And in this study, they had a lower number of patients who were encephalopathic. They had 20% of patients with I should put it this way. Only 20% of patients with neuroborreliosis had no cognitive or affective disorders. 30% of patients with arthritis. And the interesting thing about this study was that they used the mini mental status exam to decide whether or not somebody had a cognitive disorder, and they used clock drawing. And these are things that we do as an in-office exam in screening for Alzheimer's. So they're talking about how many patients met the criteria for dementia, not the kind of thing that most of us get and talk about as encephalopathy or brain fog. This is even more serious. So not that many patients don't have neuropsychiatric symptoms. So I'm going to talk about how this happens and the cellular biology of it. Direct injury, cytokines, there's a whole list. So we're going to start with direct damage. So these are very aggressive bugs. I like to think of them as really like corkscrews because they can pretty much dig their way through blood vessels. They can go through connective tissue, and they're neurotrophic. They like nerve tissue, and they like the brain. They seek out privileged places in the body that don't have a good blood supply. And so when they are invading into nerve cells undergo cell death. So that's direct damage. But most of the damage that's done is done by our own immune system. The microglia, which Dr. Frid talked about, these are the killing machines of the brain. And that's a good thing. We need to have them there. They get turned on by having a bug in the brain. And when they get turned on, they release cytokines. Cytokines are signaling molecules that tell other blood cells to come over and do their thing to get rid of this threat. And this is a great thing. But the second step of what normally happens when we have infection doesn't happen. And that's that this kind of immunity, called cell-mediated immunity, generally leads to the production of antibodies which kill the bacteria or the virus or whatever it is that we have. And those antibodies also carry memory so that they're there and ready the next time that you're exposed. Well, that immunity, humoral immunity, doesn't get turned on. So we end up having ongoing type 1 inflammation in the brain. So we were not really meant to withstand that kind of inflammation. So we're talking about the kind of inflammation of when you sprain your leg or get a cut. It's really very acute with swelling and all kinds of things happening, and it's meant as a first step before the body does something to heal. But antibodies are not effective. Antibody response is depressed, and it's not useful. So the early signaling keeps continuing. So the microglia, in their activity, they also release neurotoxins. Some of them are oxygen radicals, and they kill cells. They kill bacteria, but they also kill nerve cells. Nitric oxide, again, it kills bacteria, but it can also kill nerve cells. And quinolinic acid, which I haven't found any good use for, it just kills nerve cells. So I want to talk a little bit about quinolinic acid in particular, because in patients with central nervous system Lyme, it's very elevated in the CSF. But also in patients who don't have central nervous system Lyme, but do have chronic Lyme, it's still elevated. And those are patients who are encephalopathic. All patients who are encephalopathic have elevated quinolinic acid. They also have an overproduction of nitric oxide, and that causes oxidative stress and causes neurodegeneration. So the quinolinic acid, this is my favorite toxin of the moment. The metabolism of tryptophan, which is a key amino acid, becomes altered by an enzyme called IDO. And on the one hand, we can make serotonin or melatonin, or we could go down this IDO path that leads to either quinolinic acid or quinolinic acid. And IDO is upregulated when we have cytokines being released by the microglia, especially TNF-alpha. So with that upregulated, we're making a whole lot of quinolinic acid. Now, to degrade quinolinic acid, you need magnesium. To make serotonin, you need B6. What's really important to the brain is that it can get rid of the quinolinic acid as fast as it's being made. And so getting rid of it is a key process. And the hippocampus, which is our center for learning and memory, is particularly bad at removing quinolinic acid. So I don't think it's a coincidence that people have problems with memory and with learning when they have chronic Lyme disease. It's the hippocampus that's being hurt. It also produces damage by being an excitatory agent, and excitatory neurotransmitters are good and necessary. We need them to function, but if they overfunction, they cause cell death. It causes oxidative stress, it damages mitochondria, and it disrupts the blood-brain barrier. It even induces more inflammatory molecules. So you also get more quinolinic acid diffusing in through the blood-brain barrier that's damaged. You also have more nitric oxide. And a recent study that I read shows that it's associated with the formation of what look like neurofibrillary tangles. And that's a very specific word in pathology because that's what an Alzheimer's brain looks like, a lot of tangles. This is a rat study. These rats were injected directly into their brain with quinolinic acid, but beforehand, some of them were given magnesium sulfate just subcutaneously in their skin, and it protected against the injury of the quinolinic acid that was injected into their brain. So other things that are protective against quinolinic acid, minocycline. So we can choose an antibiotic that also has some effect on this inflammatory marker, MAO inhibitors. And in the pipeline are KMO inhibitors, which I think are going to turn out to be really important because they allow the brain to make the quinolinic acid, which is neuroprotective. They're not out yet. Homocysteine accumulates in the brain, and that's also an excitatory neurotoxin. It depletes ATP, and it kind of highlights a role for maintaining methylation. Ammonia is very important and I think underestimated. It's an exotoxin of Borrelia. That means it's a product of the metabolism of the Borrelia organism. It's what it excretes. It's like it's urine. So you have the Borrelia excreting it, and at the same time you also have things happening in the GI tract that produce ammonia. And ammonia is nothing but a toxin. It has no good role in the body, but the body is generally very good at removing it. When is it not? It's not good at removing it if you're making more than you can get rid of. Patients with elevated histamine levels have a hard time getting rid of it, and they have more ammonia toxicity. These are the symptoms of ammonia toxicity, and these are also neuroexcitatory symptoms: anxiety, insomnia, muscle cramps, and encephalopathy. And I have to say that I find that the insomnia is the one that's really the key, because insomnia really does improve if you get the ammonia down. Patients who are going to have a hard time metabolizing ammonia can have CBS mutations frequently, so it's worth looking for them. CBS mutations have to do with how we handle sulfur. And while sulfur is the kind of thing that most people need more of and not less, because they're foundational to lots of important proteins, and they're foundational to glutathione, which is our body's favorite antioxidant, people who have CBS mutations can't use sulfur and end up accumulating ammonia as a byproduct. So they're an important group. They're a group of patients who are going to have a hard time getting better. Lowering ammonia is something that doctors have done forever because we're used to it from liver disease. But when it's moderately elevated, ornithine, citrulline, and NADH can be extremely helpful. They help the ammonia feed into the urea cycle, which disposes of them. And in patients who have CBS mutations and are in crisis, lactulose, which is a sugar that's used for patients who have hepatic encephalopathy to lower their ammonia, that's very effective. And I've used it in my patients with CBS mutations to great effect. It's not what they want to take every day, but it's a great rescue. There's also stress to the endoplasmic reticulum, which is something that I really hadn't thought about in decades and decades, but it folds proteins, and proteins end up misfolding. And that has implications for things that we can do to help. There's one medication that's been found useful in ALS that works on the endoplasmic reticulum. And it causes mitochondrial damage. And with mitochondrial damage, we have a lot of oxygen species that will then react with proteins and with fats and do destruction to them, and even to DNA. So reactive oxygen species are really a toxic environment. And mitochondria are our powerhouse. They're our powerhouse, and they detox. So if your powerhouse is damaged, you're not going to have energy. And if you can't detox, you're going to have more problems with neurotoxins. And molecular mimicry, which was really what Dr. Frid was talking a lot about. We make antibodies to the surface proteins on the Borrelia, and antibodies to OSPA particularly can cross-react with human nerve cells. This particular study that I have up here was a study of patients who had post-Lyme syndrome. And in this study, 50% of them had autoantibodies, and the authors took that as proof that post-Lyme syndrome was an autoimmune disease and not a bacterial disease. I don't see that as proof of it at all. And some of these autoantibodies can cross-react with nerve. Others cross-react with other things. They can cross-react with kinds of white blood cells. But the ones that cross-react with nerve are particularly of importance in psychiatry, and they're associated with PANDAS and with OCD more than anything. There's also a theory about impaired dopamine function. This was a recent study that showed that there was a chemical in the saliva of ticks that sulfonates and neutralizes our dopamine, and the authors thought that this persists in some way, and I'm not sure how it persists, but they postulate that there's a reward deficiency syndrome happening as well as everything else. So in summary, we've got cytokines, neurotoxins, antibodies, damage to mitochondria, and damage to the endoplasmic reticulum. These are all happening in the brains of patients who have chronic Lyme. It's patients who are untreated, undertreated, and some patients who were seemingly treated adequately but simply have persistence. Co-infections make everything worse. There's a kind of conventional wisdom that Babesia is associated more with anxiety, panic disorders, and depersonalization, and Bartonella with rage and psychosis. I haven't really seen that in my practice. I've talked with Dr. Bransfield and asked him if he really thinks that this is true, and neither one of us think that it's really that clear. So maybe to some extent, but there's no airtight distinction. Co-infections just make whatever you have worse. So what's the progression? It starts off with encephalopathy, and this can occur quite early. It's really, it can start within months. So 90% of patients have encephalopathy on neuropsych testing, as compared with the study I showed earlier, which used criteria that are really more appropriate for dementia. It's very similar to ADD. I think there are a couple of things that I would say are different from ADD, or the way we've typically thought of ADD, but as I've spent more time thinking about this, I think we just have never really looked for them in kids with ADD. And that is that there's a kind of verbal fluency with incorrect words that I don't think you see with kids with ADD so much, and a lack of motor automaticity. So when I first got sick, one of the things that happened, well, there were two things that happened that had to do with automaticity. One was I noticed that when I went to make my coffee in the morning, when normally my hand would just reach for the milliliter, reach for the coffee, reach for the pot, I had to think it through one step at a time. Okay, Jane, now get the milliliter. Now get the filter. The automaticity was gone. I got lost. 5 days in a row, I drove my kids home from school and couldn't find my house. 5 days. It was really terrifying. Trouble using the ATM. So these are things that I think of as being somewhat specific, but I'm not sure that people look for them in what they have considered ADD in the past. Imaging, MRI, CTs, and SPECT scans can be abnormal. I don't think they're necessary for the diagnosis, but I do SPECT scans, and I do them at Columbia. 70% of patients with late Lyme involving their CNS, which all late Lyme does, will have multiple areas of hypoperfusion. And while I don't really find that it's necessary to make the diagnosis myself, it's often necessary to document it. It's very objective criteria. It's something that you can share with other physicians. And so I do it for that reason more than any other reason. And if I think a patient is going to need IVs. It mimics ADD. So this study was a study of adults who were complaining of brain fog from Lyme disease. And a study was done of them, and they had neuropsych testing. And the conclusion of the study was that they don't have chronic Lyme disease, they have ADD. Well, I think most of you will conclude, as I did, no, what this means is that people with ADD have Lyme disease. So I think that in any adult who presents and says, I have ADD, you've got to look for infection. And I also think that you have to do that in kids. I wouldn't have said that a few years ago. I wasn't as clear, but I think there is no such thing as any syndrome. There's no ADD. There's cognitive dysfunction and executive function impairment. There's encephalopathy, and we have to look for a reason whenever we see it. What causes it? Cytokines, quinolinic acid. They have both been identified in patients who have encephalopathy. Sleep is very disturbed in Lyme disease. And in patients who were studied and had their sleep studied, it was found that they had an increased sleep latency, trouble falling asleep. Then they had fragmented sleep. Their delta sleep was disturbed, and that's the deep sleep. And they also had something very disturbing called REM intrusion. And that was a small number, but it's very important. And that's usually when you're sleep deprived and you're deprived of your dream sleep, which is REM sleep, when we're normally paralyzed. Our body really wants that REM, and so what it does is it brings it on earlier. So as you're falling asleep, you start to dream, and that's experienced as hallucinations. So anybody who says that they hallucinate at night is probably having a sleep disorder. They have hypnagogic hallucinations, and it's probably because they're sleep deprived. But they also feel paralyzed, not necessarily the same night. It could be a different time, but the REM intrusion could manifest itself as paralysis, in which case you're awake and you feel paralyzed. I find that patients often switch their sleep-wake cycle. I think some of that is about being overstimulated during the day and exhausted. I think some of it is also because, in a way, it's less lonely to be sick alone at night than it is during the day. And I think people prefer being awake at night when nobody else is, when they're very sick. Sleep deprivation damages nerves. It damages mitochondria. And there was one study done where they had college kids playing games all night and missing one night of sleep, and they showed signs of nerve death by morning. So we have to treat the sleep. It's very bad for you. Depression is very widespread. The lowest incidence is about 40%. The highest is 80%. In the general population, 16 to 20% of people will be depressed at some point in their lifetime. But the prevalence of depression among our patients is extremely high. And, you know, the key players in that are probably, this is not working quite right here. Okay. The key players in that are cytokines. IL-168, tumor necrosis factor. These are really important key players in depression. Also, there's something called sickness behavior, which is cytokines in the periphery can diffuse through into the central nervous system and tell our brain how to behave. If you get the flu or you get a cold, you don't want to get out of bed, you don't enjoy anything, you don't want to move, you feel really down. If that were happening and you didn't have a cold, you would label those symptoms depression. And there are antidepressants that are kind of marketed for people who are in pain, and they're saying, well, it's like sickness behavior. So sickness behavior is, without knowing that there's a bacteria, looks like depression. So our patients are depressed because of cytokines and quinolinic acid more than anything. In 24 studies of patients with major depression, a significant number had elevated cytokines. And it's associated with treatment resistance. So patients who don't respond to antidepressants, about a third of them have inflammatory markers. Quinolinic acid induces depression. That's reversed by ketamine, but it's very transient. Let's see if this. Okay. Oh, and this is where I want to tell you about the bicycle boy. Have any of you heard about the bicycle boy? Oh, good. I get to tell it. The bicycle boy was a young boy. He was 12 years old. He had Lyme disease, Lyme arthritis, and was treated and was hospitalized at Mass General Hospital. And he didn't get better with any antidepressants. And they allowed the psychiatric resident, Dr. Packner, to do what he thought he needed to do, which was treat him with intravenous antibiotics. And the boy got completely well. And he got well, after 2 weeks. So an estimate would be like 40% of our patients are depressed. They also have anxiety, and those are two ends of the same coin. So I'm going to tell you a little bit about Esther, who came to me 25. She was complaining of anxiety and panic attacks. And her mother had killed herself when she was 15. And I heard this story, and I thought, well, I'm a psychotherapist. This is a typical story that I hear with pathological mourning. I'm going to work through her relationship with her mother and her mother's death. And over the next few sessions, because I do get a medical history, it turns out that she fainted 3 times in the last few years. And she had been to her primary care doctor and a cardiologist and to the ER. She had a mega workup. She had EEGs, Holter monitor, she was in a coronary care unit. And in the end, they didn't find anything, and they put her on anticonvulsants, saying maybe it's a seizure disorder. But nobody took her blood pressure sitting and standing. Now, a lot of you know that a lot of our tick-borne disease patients have autonomic dysfunction and get dizzy when they stand up. Her blood pressure tanked when she stood up. It went to 60/40. Her pulse was 125, and she was extremely dizzy. That led me to get a Western blot on her, and it was positive for anaplasm, and by the CDC standard, it was negative for Lyme, but it had, particular bands that were specific for Lyme. And so I treated her for Lyme and Bartonella. Intrusive symptoms are also very common. 34% of our patients have them, and they're a contributing cause to both suicide and violence. The next statistic is a little bit off. I'm going to skip it. I should have taken that out. So what do the intrusive symptoms look like? Well, Dr. Stricker was the first to describe musical hallucinations. And when I read about this, I hear a song and it won't stop playing. I realized that my Lyme probably started at least 15 years earlier than I thought it started. And it started with a Pepsi-Cola commercial that wouldn't stop playing in my head and let me sleep. And it was really intrusive. It was not a hallucination, but it's like a strong earworm. Intrusive thoughts, they come from out of nowhere, and they're horrible thoughts usually, and they're about things that don't really make sense. So I have one patient now, she's a Princeton student, and she has an obtrusive thought as she's driving that she's caused a car accident behind her, and it will stay with her for the entire day. So driving is a real difficult thing for her. Religious, catastrophizing thoughts, the need to tap, just tapping your fingers, and what I call cognitive tics, which are spelling, counting, saying nonsense syllables. These are very annoying to people. OCD. I think both OCD and some of the intrusive symptoms are sort of disorders of will. They're things that happen against your will, and your self really doesn't want them. So Lee is a 17-year-old patient of mine. Well, she's not a patient anymore because she's really done well. She missed out on much of elementary school. She couldn't take tests. She couldn't take any computerized tests because she needed all of the A's and the E's to line up, and the B's and the D's. She needed total symmetry. And she was agoraphobic. And I treated her for Bartonella, and she went back to school for her senior year. James has OCD. He's being treated by another doctor, and every time he started on zithromycin, his OCD flares, and he just has to wash and wash and wash. And managing psychiatric herxes is a real issue. Suicide. Dr. Bransfield published a piece this year where he deduced or calculated a projected amount of suicides per year from the current incidence of Lyme and a chart review of his patients and what % of patients with psychiatric symptoms have suicidal ideation or complete. And he surmises that there may be as many as 1,200 suicides a year. And, one of the things about suicide is that it also is associated with inflammation and quinolinic acid. And quinolinic acid has consistently been found higher in patients who suicide. We don't usually know that somebody's killed themselves because of Lyme. This was something that really struck me. This was a general practitioner who hanged herself. And if you look at her face, you can see evidence of a Bell's palsy, and it made me think that she had Lyme disease. 41% of children with Lyme have suicidal thoughts. that's just astonishing to me. And, that's both on a study and then on a scale of really specifically asking them. 11% have made suicidal gestures. A lot of the kids are diagnosed with school refusal, and you have to talk to them really carefully to find out what's going on. They're having all kinds of horribly painful symptoms that they can't describe and can't share unless they have somebody who can really ask them about the specifics. They can be very sensitive to sounds and light. They can have difficulty processing the information that's coming in. They're tired. They can't keep up with their friends. They can't have friends. The whole thing of Lyme is a crime, but the biggest crime of all is that we're doing this to our kids. And this is our nation is doing this to its children. Our children play in the grass, they play soccer, and they're just getting so sick. Depersonalization is another symptom that seems to be specific to Lyme, much higher than you would find in a regular population. And I don't have any patients who are complaining of depersonalization, but I did a search online at self-help groups, and there were a lot of patients with it. And so these are the kinds of things that they would say, that they would look in the mirror and they don't really feel quite real. And there's a sense of great distance between yourself and the rest of the world. And it's very painful, and it puts people at risk for suicide. Violence. Dr. Bransfeld has a large collection of patients who have had Lyme rage and have acted out, and also Bartonella rage. I can tell you about one girl who's now 13, and right now she's in a wilderness school because she's not well enough to be in a residential treatment center. I was treating her mom in psychotherapy, and by age 3, she was having horrible, horrible rages. And it took a long time for me to get the mom to get her tested. She was a very athletic girl. And by that time, she quickly became frankly bipolar, and she's been hospitalized. And she was extremely violent. And now she's getting treated. And I hope that the story has a good outcome. There's a psychotic presentation. And so there are cases of schizophrenia that then are tested for Lyme and have tested positive and have remitted with antibiotics. In the recent literature, there was a study of a schizoaffective patient this year. So Dr. Fallon has studied the greatest number of psychotic patients with Lyme disease. And there's a feeling that Bartonella is the co-infection that's most associated with this. I'm not so sure. Rosalie Greenberg did a study of 27 bipolar kids, and 90% of them tested positive for tick-borne disease. What can one say? 90%. And we're seeing more bipolarity in kids. When I was a resident, we were taught that bipolar disorder was something that occurred in the 20s or 30s. Bipolarity is associated, schizophrenia is associated with interleukin-6. Bipolarity is correlated with interleukin-10, which waxes and wanes throughout the course. And interleukin-10 is stimulated specifically by Bartonella. In general, it's a down-regulator. And in fact, with bipolarity, it's up when people are having episodes, and it's down in between. Pandas. So the pandas are a product of molecular mimicry. We make antibodies to a bug, and they cross-react with nerves. We have typically thought of this as being due to strep. It was known to be due to strep for a really long time. But it became clear over the years that it's due to a lot of organisms. H. flu is one of the common ones, but Lyme is also common. And there are standards for the diagnosis of pandas. And it generally is a sudden onset in childhood. There are a lot of emotional changes, irritability and aggression, OCD. school refusal, behavioral changes. So any kid who has a sudden onset of any psychiatric symptoms deserves to have antibody studies. And there's a workup that's outlined for them. This is the official workup from the Child Psychiatry Association. Dr. Jones sees lots of these kids, and he says they do very well with antibiotics, but if antibiotics fails, he gives IVIG. And if IVIG fails, he does plasmapheresis. And these are guideline-driven treatments that are acceptable for pandas. Autism spectrum disorder is also associated with Lyme disease, and there were 5 case reports of kids whose autistic symptomatology disappeared when they were treated for their Lyme. And Alzheimer's. And there are a lot of autopsy studies now, and Dr. McDonald, has been in the forefront of doing this work, but also Dr. Muklasey, that there are spirochetes in the brains of Alzheimer's patients greatly out of proportion to controls. And while many of those spirochetes are from oral pathogens, many are from Lyme. So this is what you really want to know is treatment. And why did I go through all of that? If you're not, doctors or researchers or pathologists, well, they do point us in directions for what can we do to help with symptomatology and help people feel better while they're being treated for the organism. Nothing I say about treating psychiatric illness means that we can make the psychiatric illness go away if we're not getting rid of the organism. That inflammation that we have that's ongoing is ongoing because there's a stimulus. There are organisms. So we can do things to suppress, to stop, to turn off the inflammation, but nothing is going to totally stop it until we get rid of the initial threat. So anti-inflammatories are being studied for psychiatric illness, and the jury is really out on them. The literature is mixed, and we can't say that it's time to do it. Fish oil has been shown universally to be helpful and well tolerated, and that's true for bipolarity, and it's true for depression. And in some studies, it was as good as antidepressants. The only anti-inflammatory that has really had any significant results in studies of depression has been Celebrex. And that crosses the blood-brain barrier well. And it's been useful both as an adjunct and on its own. But we need more studies. Most of the big guns are really not appropriate. So, we know that things like Enbrel that are used for rheumatoid arthritis can help some patients with depression. If you have psoriatic arthritis and you're treated with Enbrel and you're depressed, even if your arthritis doesn't get better, the depression might lift because a lot of it is caused by inflammation. But there have been a lot of studies lately, and they're not coming out as showing any kind of robust results. As I said, fish oil and Celebrex seem to be the only thing so far. And these aren't large. The fish oil is a large study, the Celebrex is not. But I do believe that we should treat the inflammation. So I think this is part of treating the terrain, and this is doing everything we can to help people. Yes, take pictures of this. 5 minutes? Oh my God. Okay, so just take pictures. And just remember magnesium and vitamin B and glutathione. Those are the important ones. There are potential targets for the excitotoxicity. And what's most important here is that magnesium comes up again, and acetylcysteine and boswellia. And boswellia is interesting because that's frankincense. It diffuses well across the blood-brain barrier, and it has FDA approval for use in metastases for cancer in the brain. So potential treatments for mitochondria and endoplasmic reticulum. TUDCA for endoplasmic reticulum. This is a list of what we can do to improve mitochondrial function. Herxheimers are something, the psychiatric Herxheimers are a real problem. And I get a lot of referrals from people who are treating Lyme and saying, I want you to take care of this patient who's going to get psychiatrically worse when I treat him. Because the outer wall of the Borrelia is covered with endotoxin, lipopolysaccharides that stimulate cytokines, so that when we give the antibiotics and the bacteria dies, it's released all over the place and there are more cytokines. The OCD gets worse. Patients have manic episodes. They can get suicidally depressed. And they're sent to me, please prevent this. So this is my recipe. This is to take a photo. And it comes down to dilute, alkalinize, expel, and try to calm. So my recipe is 8 ounces of water as soon as you think you're having a herx, with 2 Alka-Seltzer and 2 lemons, 1,500 milligrams of liposomal glutathione. If there's any flushing, Benadryl, because there could be mast cell activation. And then magnesium. And one of the reasons that you'll hear about Epsom salt baths all the time is that Epsom salt baths are a very good delivery system for magnesium sulfate, which, as you saw, is very good in the brain for all kinds of neuroinflammation. Apple cider vinegar is also excellent. It also enters the brain, it delivers acetate, and that also is very anti-inflammatory. If that doesn't work, there are a lot of people who feel that they have benefited from Nutrimedix's Berber Panella Detox, and so I recommend that. And I also think that when you have a bad psychiatric herx, it's worth giving ornithine for ammonia also. In general treatment for encephalopathy, we can improve cognition with citicoline. Coconut oil is also helpful. Sometimes stimulants. If I'm giving an antidepressant, I'll choose Wellbutrin, but some patients will benefit from Provigil. And I treat all the symptoms, and I think it's really important that we try to help people sleep. Lamictal is very helpful for bipolarity and irritability. Neurontin and Lyrica. But what I really want to get onto is the emotional issues, because this is the most stressful illness I think a person can have. It's very lonely, and it causes a whole change in the sense of self. Am I able? Am I disabled? What world do I live in? People have been gaslighted by the medical establishment and by their family. It's very overwhelming. So I think psychotherapy of all kinds helps. I think faith groups can be very supportive. I believe in spiritual connection. I think that's very helpful. I teach mind-body techniques, and I think they're also very important. Meditation in particular, grounding, qigong. But I think like the issue for how to work this through is to make meaning from it. And the way what I think is the best way to make meaning is to either be the vessel or be the light. So if you are depleted and you are in need, and you put your arms out and say, let me be the vessel, there are a lot of people who will be the light, and they get to experience that. And if you're feeling well, then you be the light and you give so that somebody else can receive. And if you are positioned in either place as the vessel or the light, you are involved in true healing. And that's about the most important thing that we can do for our emotional health, is to be part of a healing community and to be healing the world. Thank you.